Hello, and welcome to today's Talk with the Doctor series. I'm extremely honored to be introducing Dr. Mike Erkkinen, who will speak on what's new in Alzheimer's disease treatment. My name is Neil Collins. I'm a retired environmental attorney, 8-year participant in the Biogen Donanemab project drug trial in the Center for Alzheimer's Research Treatment at Brigham and Women's Hospital. I've offered to introduce our keynote speaker and tell my story, as it was through Dr. Erkkinen that 8 years ago, I was introduced to the Biogen drug trial, in which I've been considered a responder. My life of 40 years, who has been my study partner on this project and journey, and I will be always extremely grateful to Dr. Erkkinen for opening this door for us. The Talk of the Doctor series is organized and run by Research Ambassadors Group, of which my wife and I are both members. The Research Ambassador Group is a volunteer branch of the Massachusetts Alzheimer's Disease Research Center. Research Ambassadors are a volunteer group made up of both current and past research study participants and their study partners. The Ambassadors program primary purpose is to spread awareness about the importance of engaging people from all communities for research studies and sharing current, explicit, and pertinent information that serves their needs and our needs. We're so grateful that all of you have joined us today. Before we begin, I want to take 2 minutes to share a few housekeeping details. Please stay muted. Information on today's presentation will be sent along with a follow-up survey. Please help us to stay relevant in our community by completing the survey. Please put your questions in the chat. We have several resources on the www.madrc.org website. Now I'm extremely pleased to introduce today's speaker, Dr. Mike Erkkinen, who has graciously found time in his very full schedule to speak with us. Dr. Erkkinen is a cognitive neurologist and the clinical director of the Division of Cognitive and Behavioral Neurology at the ambulatory director of Brigham's Neuroscience. Dr. Erkkinen also leads the development and operations of the Alzheimer's Therapeutic program. And now we welcome Dr. Erkkinen.
Neil, thank you so much for that wonderful introduction. It's great to be here, everyone. Let me share my slides with all. Slides will be there to help guide us, but again, hopefully I don't want to be too anchored, I guess, and if people do want to, well, I don't want to supersede the rules, so we'll go ahead and get started. So this is a new era of Alzheimer's disease, as I'm sure some folks are aware. You know, we have new Alzheimer's disease treatments that really, target the disease itself as opposed to the effects of the disease. So this is a very exciting kind of era that we're entering, and I'd like to, share the updates, with everyone here today. So just some background. I'm sure we're familiar with this. Alzheimer's is common. About over 25% of folks over the age of 65 either have MCI or mild cognitive impairment or dementia. And about half or so of MCI, the mild cognitive impairment, is due to Alzheimer's. So Alzheimer's is very, very common. Our treatments as of now are, one is we will help to manage symptoms using medicines and other interventions. We also really encourage healthy lifestyle habits. We're learning, every day there's a new study, it seems, that talks about the benefits of exercise, of healthy eating, of sleeping well, and so on and so forth. So we really advise healthy lifestyle habits. And we ask folks to address, a modifiable, factors. So that's not only healthy living, but that's also things like hypertension, high cholesterol, sleep apnea, other medical issues, and things like that. And there's some studies that suggest that almost half of one's dementia is perhaps, due to modifiable risk factors. And then we obviously would put an emphasis on safety as someone, as one's, a memory gets worse, there's a risk of there being safety issues. So we think actively about that and try to be ahead of that. So to try to prevent any unsafe outcomes. And then, of course, we think about long-term planning, safe living environments and so on and so forth. That's kind of how we manage Alzheimer's now. It comes with a high cost, of course, number one, to patients and their families, but of course to society as well. And when I say cost, I don't just mean the financial cost. I mean the emotional and spiritual and other tolls that this takes on all of us. Let's talk about sort of how we think about a treatment for Alzheimer's. So we think there's a disease called Alzheimer's, and it causes the brain to become injured, and then those brain injuries lead to one having symptoms, right? So our medicines that we have so far, they really are targeting symptoms, right? So for example, things like Aricept, which is under the heading of a cholinesterase inhibitor. Alzheimer's disease injures the parts of one's brain that generate acetylcholine, and then we use a medicine to help replace the acetylcholine, and that can alleviate symptoms. So we're responding to the kind of effects of Alzheimer's, but we aren't actually treating Alzheimer's disease yet. Same thing here with SSRI. These are medicines like Lexapro, escitalopram, and others that can affect one's, mood and irritability. Alzheimer's injures the parts of the brain that generate serotonin and other, molecular causes of irritability, and we use medicines to help replace those. And that's kind of been our model. We haven't really gone after the Alzheimer's disease itself. We've gone after the effects of Alzheimer's disease up until now, where there are new agents, which is very exciting. And we'll talk a lot about these that actually target the Alzheimer's disease itself. They go after a protein called amyloid, and amyloid is thought to be one of the earliest and most important causes or elements of Alzheimer's disease. So let's talk about lecanemab. So the main FDA-approved agent now that targets amyloid is called lecanemab. So what is lecanemab? It is an antibody. It's made in a lab, and it gets infused IV, intravenous every 2 weeks. And this antibody, it binds amyloid. Again, amyloid is one of the abnormal proteins in Alzheimer's. It binds amyloid, and it takes the amyloid out. And it uses the immune system to help, take the amyloid out. So that's how it works. It has now been shown in studies, and we'll look at these studies in a moment, but it's FDA approved for MCI, or mild dementia, that's caused by Alzheimer's disease. So what is meant by MCI, or mild cognitive impairment? It's when you have a memory loss that we can see on our assessment, but it doesn't affect your everyday functioning, right? So if you have some memory loss, but yet you're still able to shop on your own and manage your meds and pay your own bills without help, that's what we would call MCI. What's meant by the term mild dementia? Well, that means you have some memory loss, and we see it on our testing, yet there is a loss of your everyday functioning and your ability to be independent in those tasks. So if you are needing help with managing your meds or using a car, that would be what's called mild dementia. And then what is meant by the term due to Alzheimer's disease? It used to be that we would look at someone's symptoms. We would perform a cognitive assessment. We would look at an MRI scan, and we'd say, this looks in total like Alzheimer's. Your diagnosis is now Alzheimer's. But with the advent of more advanced diagnostics, we have specific, a test now that can look at the biological, markings of Alzheimer's. So what's called an amyloid scan. It's an image that you get of one's brain that, can look up and find amyloid in the brain. And then you can also get a spinal tap, a lumbar puncture, which can actually, measure levels of amyloid in the brain. So if you have all of this, that's what you're approved for a lecanemab. So let's look at where the actual, data for lecanemab comes from. It was a large phase 3 trial. It was called Clarity AD, and it was published in the New England Journal of Medicine. This is a large trial it was around 1,800 patients in total. About 900 actually received a lecanemab, and the other half were on a placebo. Everyone had MCI, or mild dementia. Everyone had a cognitive test score, what's called a mini mental status exam, or MMSE. It's a standard set of cognitive tests, and they had to score above a certain amount, which was 21. And they all had to have a memory loss on their testing. So you can have cognitive impairment but not have memory loss, right? You can have some trouble finding words, or you can have some trouble staying focused, and so on and so forth. Everyone had to have some actual memory loss on their testing. There's a test called the Clinical Dementia Rating Scale, or CDR, and it's kind of a semi-structured interview that helps the doctor assess one's a level of impairment. It's probably the gold standard we have for assessing one's dementia rating or scale or severity. And on this, they had to have a score between 0.5 or 1, and a 0.5 is roughly about what you'd expect for MCI, and 1 is what you expect for mild dementia. The higher scores are suggestive of more advanced disease, and they were not included in the trial. Everyone had to have either an amyloid scan, a PET scan that we talked about earlier, or a spinal tap that shows amyloid in the brain. Folks who had any kind of bleeding or hemorrhage on their MRI at baseline were not allowed in the trial. I'll explain why in a moment. Yet, folks who were on an anticoagulant or a blood thinner were allowed. And the trial was 18 months long. So what happened? Well, one very clear outcome is that lecanemab is very, very effective at taking amyloid out. So you can see folks here who were not on the drug, they very slowly added some more amyloid, as likely it arrived in the first place. But those who were on the drug essentially lowered their amyloid, markedly over the course of 18 months. In fact, 80% or so of everyone on the drug had no amyloid left on an amyloid scan after 18 months, at least at the levels of what an amyloid scan can detect. And they showed a similar effect in spinal fluid. So there were some folks who elected to get spinal taps. I don't know who, but at 1 year in 18 months, and they showed that the amyloid levels were improving on the spinal fluid as well. So lecanemab, it takes out amyloid very, very well. That's one. Number two, and more importantly, I think as a doctor, is that it actually helped one's, memory. So this on the upper here is what's called the CDR, as we talked about earlier. And yes, folks got, worse over time, whether they were on the drug or not. But if you were on the drug, your worsening was slower than if you were not on the drug. And it was significantly so. It was about a 30% slowing of getting worse. That led, in real terms, that was about a 5.5 months time savings over the 18 months of being on the drug. So I think a significant benefit. It also allowed folks to be independent longer. So if you were on Lecanemab, you were able to maintain your independence in your everyday activities a little bit, longer. So, so this is the main finding. It actually led to an improvement or a worsening of decline, or a less worsening of decline if you were on Lecanemab than if you were not. Interestingly, it didn't only affect amyloid; it also affected other, markers of disease. So there's another protein that's abnormal in Alzheimer's disease called a tau. Alzheimer's is really amyloid and tau, and it also, by taking out amyloid, it also affected one's levels of tau in a positive direction. So it lowered the levels of tau in the spinal fluid. And they also looked at other, markers of injury, and they found that there was actually an improvement in those as well. So taking out the amyloid seems to have an effect not only on amyloid, but on other, markers of disease. And that led to, a better clinical outcome. That's the main takeaway. Why would you not want to be on this, hearing that? Well, one is there's a very important side effect called ARIA, A-R-I-A. It's an acronym, stands for amyloid-related imaging abnormalities. And what ARIA is on an MRI scan, there are areas of swelling or edema and or microbleeds, little areas of hemorrhage or bleeding. And it sounds pretty scary to hear that. It's not uncommon. About 1 in 5 on the drug will have ARIA, again, either the swelling or the microbleeds on their MRI scans. It's the highest risk is in the first 6 months of treatment. What is somewhat, reassuring is that most of the time you would never know you have it unless you got an MRI scan. So only about 3% of everyone on Lecanemab would have symptoms with ARIA, right? So, and when they do have symptoms, it's usually mild, a headache, a dizziness, and so on. Yet, there are cases of serious ARIA, a large bleed, a lot of swelling, seizures, and some folks have even died from ARIA. So it's well less than 1%, but nevertheless, it's a very important thing that we should be aware of, that there are, rarely cases of serious ARIA that might be life-threatening. So what are the risk factors for ARIA? Well, at baseline, if you get an MRI scan, and everyone is sort of required to have an MRI scan, if you have, microbleeds on your MRI scan at baseline, that would be a risk factor for having ARIA when you're on treatment. There's a gene called ApoE. It's well known in Alzheimer's because there's a particular variant of the ApoE gene called E4 that raises your risk of having Alzheimer's disease in the first place. It also raises your risk of having ARIA. So it's a double whammy, having an E4 allele, and it's even worse if you have 2. So we always make sure we look at an ApoE gene test well before someone starts on treatment to help them make a decision. And then it was found retroactively that if you were on a blood thinner, your risk of having ARIA was higher, and having a macro bleed, a larger bleed, was a little bit higher. ARIA is something we take very, very seriously, and you have to get a multiple MRI scans in the first 6 months of treatment just to look for it and make sure that we're not missing it. And of course, if you have ARIA, there's a range of responses, right? If it's bad, you have to stop the treatment forever. If it's mild and you don't have any symptoms, there's actually a time when you can actually stay on the drug and just get MRIs every month to make sure it's not getting worse. So what are our efforts? So that's kind of the overview of Lecanemab, how it works, why it's good, why it's harmful. And now let's talk about what we've done here at MGB, Mass General Brigham, to help offer this to our patients. So we're calling it the Alzheimer's Therapeutic Program for obvious reasons. And it's really our effort to bring this new treatment to our patients. Our main goal is safety, making sure everyone has an MRI at the right time. You're making sure we know the evidence of who should be on it and who shouldn't, and following that very, very closely. Of course, 1B would be sort of equitable access and being efficient, so we can offer this at a large scale for folks who really need it. There's two stages in our program. Of course, the first is upfront. Who's a good fit for this? So there's, we get MMSE scores. We do a history. We do an exam. We get an MRI scan. We get an ApoE gene test. We get an amyloid scan or a spinal tap. We gather all the data that we need to make a decision. Is this person a good fit? And then, of course, we talk about the risks and benefits, and we have them, weigh in. Is this a good fit for you and your values? So that's one element of this. And then, of course, the other element is once someone has said, this is a good fit for me, I want to do this, and we think they're eligible, then they get on the treatment. And as you said earlier, it's every 2 weeks infusion. So we organize those, we organize the MRI scans and so on and so forth. So there's the being on the treatment and being, monitored safely. Probably beyond the scope, but maybe I should have taken this out. But what's interesting about our model of care is that the doctor is always rotating. So it's like there's someone on service, but there's a core kind of team who's looking at everyone's infusions, MRIs, and so on and so forth, and letting the on-call sort of, doctor know what tests need to be looked at and followed up and ordered each week. And this is, I think, a safety way of if a doctor were to leave or have to not be around, you're not left in lurches. You have a core team who's helping to organize your care. Okay. So, and then things that people should be aware of for emergencies. So if you were to be on Lecanemab and you were to have a stroke, life happens. People are older, usually with Alzheimer's, and strokes are not uncommon in older adults. It's very important that if you are on Lecanemab, you should not receive a medicine that can break up clots. And that's the standard of care for acute strokes. So the reason why I mention this is because it can increase your risk of bleeding. There was a case report of someone who was on Lecanemab. They had a stroke. They went to the emergency room and they got the a medicine that can break up a clot, and they had a fatal hemorrhage. They actually died. It wasn't here, it was another site. So we saw that and we've said we don't want anyone who is on Lecanemab to receive those medicines, even if they have an acute stroke. But there's other ways of treating a stroke. Aspirin is okay. They can actually, go in with a device and take out a clot, and that's okay, with a actual retriever. And then if someone wants to start on a blood thinner, it's nuanced, right? We know there's a higher risk of ARIA and having a bleed. It's not a massive risk. It's not as high a risk as we think those acute, medicines are that you would use in the setting of an acute stroke. So like a blood thinner would be like Eliquis or, Coumadin, something like that. So we want to be involved in those conversations about the risks and benefits of those. And then if someone were to have severe ARIA, right? They were one of the less than 1%. They need oftentimes would need to be admitted to the hospital and managed more aggressively to try to prevent any long-term negative outcomes. Of course. Okay. We've grown a lot in the past year. So this was FDA approved last summer, and now we started our clinic in October of last year, and we started our first infusion a couple months later. And since then, we've seen over 300 patients in clinic, and over 150 are on Lecanemab, and there's been over a 1,000 infusions. So we're off and running here, and we're continuing to expand our efforts. And it's really an effort between the Brigham and MGH. It's really kind of an MGP-wide effort. And I'll explain a little bit more about that. You know, we meet as a group, again, across campuses every week for an hour. We're calling it the ATP plaque and tangle board. That's a reference to what Alzheimer's looks like under a microscope. There's amyloid plaques and tau tangles. So we call the plaque and tangle a board. And we talk about cases that are kind of on the edge, right? Are they eligible or not? Here's a subtle finding that might or might not be ARIA. How should we manage it, and so on. So we're learning as a team on these nuanced areas in this, a new field of Alzheimer's treatments. Kind of a rising tide here, I think, lifts all ships. And then we meet multiple times a week and elsewhere to talk about how our program works and how we can make it better. So this is a very much a kind of a always improving effort. So what does it look like if you get referred, or if you're interested in being referred? Well, one, your doctor or your referrer has to make sure that you have MCI or mild dementia. They have to suspect that Alzheimer's is the main cause of your symptoms, right? Sometimes people can have other illnesses and then also have Alzheimer's, but if they think the other illnesses are the main reason for your symptoms, you wouldn't want to expose yourself to all the risk of the Lecanemab if it's only going to have a small effect on your overall symptoms, right? So Alzheimer's has to be the suspected, a main reason for one's symptoms. You should have had a cognitive screen within about a year or 6 months. The MMSC was one that we mentioned earlier, but there are others. There's a test called the MoCA, which is also used. And there are certain scores we use as kind of guidelines, although I will say there's lots of reasons why someone might have a low score that doesn't necessarily reflect the stage of their disease. So we oftentimes, if it's the right sort of context, we can make exceptions for low scores. You have to have an MRI within a month, within a year, and there can't be the exclusionary features that we talked about earlier. Importantly, any bleeding, but there's other reasons why there's things you can find on an MRI scan that might exclude you beyond that. You have to have a positive Alzheimer's disease, a marker test. That would be an amyloid scan or spinal fluid. There's interesting expansion now into having a amyloid sort of blood test, but we don't think that's ready yet for our eligibility. So we still are requiring folks to get either an amyloid scan or a spinal tap. And then there's reasons why you'd be excluded. If you take a blood thinner, you're not eligible. If you have a bleeding disorder, if you have immunological, diagnoses that would require you to be on immunological medicines, that can make the drug not work as well. So there's other reasons why someone might not be eligible that go beyond the things that we've talked about already. After you're referred, someone from our team will look at your chart and make sure all the elements are there. We'll see you in the clinic up to 1 or 2 or even 3 times to make sure that you're a good fit and that this aligns with your values. And then once approved and you've sort of offered your consent, then you'll get infusions every 2 weeks. And we're offering it at the main campus here at the Brigham, at the Faulkner Hospital, and then MGH Infusion Center. Right? That was a typo. I'm used to typing MGB these days. That's at the MGH Infusion Center. And then you'll get those multiple MRIs in the first 6 months. They're required. You won't be able to get your next infusion unless you've had an MRI at the right time. And then if you have ARIA, then we oftentimes will get even more MRI scans. So it's a fairly labor-intensive process to be on this. Again, perhaps it's worth it if this is a good fit for you. And then you'll come see us in the office every 6 months. And then, of course, as needed if there's any sort of urgent issues. So that's where we are now. We have, one agent, Lecanemab, FDA approved. We're up and running, and that's where we are. Just recently, a few months ago, a second agent, what's called Donanemab, was approved by the FDA. And it has a very similar mechanism, meaning it's an antibody, it binds amyloid and it takes the amyloid out. So it does a very, very similar thing. Perhaps it targets a little bit of a different area of the amyloid, so it works a little differently, but overall, it binds amyloid and takes the amyloid out. So what's different about it from a lecanemab? Well, one, it's dosed every 4 weeks as opposed to every 2 weeks. That's a great advantage. You don't have to be in the hospital every 2 weeks. It's only once a month. But the downside is that there's significantly higher rates of ARIA, and you have to get even more MRI scans to look. So let's take a look at all this. So again, the study that was done actually similar in size, about 900 on the drug and 900 on the placebo. Everyone had a diagnosis of MCI or mild dementia. Everyone had a cognitive test score. The score was a little bit lower, right? As you recall from last time, the MMSE score for lecanemab was 22, and here it's a 20. So they let folks who were a little bit more advanced in the trial. And everyone had to have an amyloid scan and actually a tau scan. We haven't talked about that yet, but you can also get a scan to look for levels of a tau in the brain. Again, that's the other protein that's abnormal in Alzheimer's disease, with amyloid. And again, it was an infusion every 4 weeks, and folks were followed again for 18 months, the same length of a trial. What's interesting though is that they did amyloid scans at 6 months, 12 months, and 18 months, whereas the other one was just at the end of 18 months, you had an amyloid scan. And if you had no amyloid left earlier in your treatment, let's say you had no amyloid in the brain at 6 months or 12 months, you actually were switched to being on the placebo. So they had a kind of a mechanism for stopping drug. So what does it show? So it shows that like lecanemab, it was very effective at taking out amyloid over time. You can see that here. And again, similarly, about 80% of everyone on the drug had no amyloid left on their amyloid scan at 18 months. So it takes out amyloid very, very well. They showed a very, very similar effect on the same test, the CDR, that we talked about earlier, but of one's dementia rating or sort of scale, it showed about a 30% slowing. Very, very comparable to what they saw in lecanemab, and a similar effect on memory scores and on one's functional independence. As an aside, look at the clock here. They looked at people with low levels of the tau, so thought to be earlier stages of disease, and they saw a much larger effect in people with early stages or low levels of tau. So that may be something in the future that we are trying to get folks who are earlier in the illness in on these drugs, because perhaps they have a larger benefit. Donanemab has high rates of ARIA. Let's take a look at that. So about 40% on Donanemab had some form of ARIA. Again, that was 20% for lecanemab. And in those with ApoE4, remember we talked about the ApoE gene. If you had 2 copies of the E4, you actually had an over 50% chance of having ARIA. 6% had symptoms with ARIA. Again, that's I mentioned that was only 3% for lecanemab, and actually serious ARIA occurred in 2%, which is a pretty high number when you're thinking about a large number of patients. And there were actually 3 ARIA-related deaths, and there were none for Lecanemab in the trial itself. In the open label period after the trial, there were some deaths reported, again, as you mentioned earlier, from the serious ARIA in Lecanemab. So where are we with this drug? Well, it's not available yet here at MGB. We've made a formulary request, meaning we want it to be added to our options for medicines we can use. We'd like to offer it. We think there's a certain subset of people perhaps who would want to be on this over Lecanemab, and we're getting ready for it, I would say, is where we are now. So what is the future of Alzheimer's and the treatments and even our program? Well, I think it's a really unique opportunity to deliver complex infusion care, right? This is it's a complicated drug to use with all the MRIs and things, but it's an opportunity for us to really serve our communities and be able to, manage a large set of patients safely, which is something I'm excited about. But we're really interested in what's going to happen to the future of Alzheimer's disease treatment. And I think for us, it's going to be guiding folks who are appropriate for anti-amyloid treatments, and if so, which one, Lecanemab or Donanemab. I think I would suspect in the coming years, there'll be opportunities to have not an IV injection, but a subcutaneous injection, right? You could get kind of an injector at home that you could actually deliver these yourself. That would be a game changer in my mind, not having to be in the hospital every 2 weeks for an infusion. I think there are some exciting areas. There are some exciting things in the earlier stages of trials that are looking at knocking down tau, right? We've targeted amyloid now, and it seems to help. Let's look at, a tau or a mix of tau and amyloid at the same time. So some exciting work looking at, targeting tau. And there's other mechanisms that are interesting as well, including the GLP-1 agonists like Ozempic and so on. And then I think a really exciting area is looking at, are there ways to actually prevent Alzheimer's disease? So let's say you could identify someone with amyloid in the brain well before the onset of symptoms, right? They don't have symptoms yet, but they have amyloid. So they're at high risk for having symptoms of Alzheimer's later. You could intervene with an anti-amyloid antibody, and then you could actually try to prevent the onset of symptoms over time. And that's actually being looked at right now. We're one of the sites for this. It's called the AHEAD trial. So some exciting work here in the trial space that might, impact our future of Alzheimer's treatment. So that's all I had to say. I think this is an exciting era. We're now not just thinking about what the future might hold, but the future is now when we're actually starting to, treat folks with disease-modifying agents for Alzheimer's. So I've linked here a few websites for folks who may be interested in learning some more about it. I'm happy to take any questions next. Thank you.
I think we're ready for Neil to tell his story about his participation in research and how his dedication has led to some of the approval of these treatments.
Thank you so much, Dr. Erkkinen, for sharing the current research. It gives us all hope for the future. 10 years ago, my wife, Barbara, having retired from being a full-time educator, she began to notice changes. My forgetfulness became more pronounced. And thus began our yearly visits to Stephen Fesky, our first neurologist at Brigham and Women's. I was 68, my wife 63. That time, we're still able to fully maintain our lives moving forward. But then came a frightening day that changed the course of our lives. Sometimes change happens like that, at an accelerated pace. During my career as an environmental attorney, I would carry USGS maps while we were building company was building pipelines, natural gas pipelines. And I'd have the USGS maps and I'd be saying, we're getting close to a wetland. Hey, you guys, you got to skirt this. And so I understand directionality. Walking in public gardens, Barbara shared that we were going next over to Newbury Street. It's a main street downtown Boston. I lived in downtown Boston. I should have known where it was. I've been there 100 times, but I couldn't remember where it was. And I tear up even knowing that very shocking understanding to myself. How could I not know where it was? Well, Barbara pretty quickly got me over to the Brigham and Women's, talked with Dr. Michael Erkkinen, and we galvanized our strengths and began wading into the unknown and began with Erkkinen and CART. Volunteered in the Biogen Alzheimer's drug trial in its third and final phase, and it became the EMBARK study. Dr. Erkkinen, with kindness, compassion, and medical brilliance, began helping us through our path we were going to take. Helped us forward, and I've always had in science, I've always believed in science and the good it can do. With respect to compassion, he helped us see the commonalities between our own professional understanding and respect for scientific data and research when it was undertaken in the hands of smart and well-informed professionals who want to do good in the world, like all of us. I had used research to protect the environment, and Barbara had used it to making learning accessible for all children. We understood we were able to embrace this opportunity to work side by side for the common good. Alzheimer's can be lonely, frightening disease. It's quite a scary thing to recognize that your mind is fading away. Maybe just little bits only you recognize. It's not noticeable to many in the outside world. Many don't know what you're going through. You who had once had a brilliant mind, you're now stumbling throughout the day. In fact, even today, when Barbara tells me something, I cannot retain verbal information for more than 10 seconds. I just lose it. What gave us the courage to enter this study? We believed in science, Brigham and Women's community of excellence, research for Alzheimer's disease. We knew we'd have a team of doctors, nurses, and scientists watching over us with care, concern, and the rules designed to assure safety and protection throughout the drug trial. We were welcomed into this community. Every question was answered. My Alzheimer's, identified in its early stages, did not come with an immediate tragic ending to our lives. We were very fortunate. Once in the trial, we've thought about what helped us to stay at the course for 8 years and continue with our monthly infusions and all the additional tests and assessments. It sometimes had us traveling to Brigham several times a month over the past 8 years. Initially, we didn't know if I was getting a placebo. We didn't know if I would get any side effects. The Brigham team did catch an early side effect and took care of it. We were going on, and that just increased our trust in their ability to watch for you. The Brigham's team did catch the early effect. After all these years, we're grateful to be a positive responder to the drug. Just a little bit more, we have developed close, supportive personal relationships with others on the same journey and became volunteer research ambassadors, which is why I'm here today. Has my Alzheimer's been cured? No. Has the Biogen drug in our life filled with dear friends and family, careful attention to our diet, exercise, and cognitive stimulation and solace we have always found in music, art, and poetry? Has all this slowed down the impact of the dreaded disease for years? Yes, my wife and I still lead a rich, full life. Definitely yes. Do my wife and I need to continually adapt to the changes this disease imposes on my brain and on us and our lives? Definitely, yes. Alzheimer's has become an uninvited and unwanted member in our relationship. We don't know what our future is, and we haven't for the last 8 years. But we're eternally grateful for the life we've had and the help you've given us. That's it for me. If you